we have an increase in chloride, right? This is what's maintaining the normality of the anion gap, right? It's maintaining that number between 6 and 12 because it is a measured anion. And when I had a question, what do I mean when just basically, what do I mean by measured, unmeasured? It means what's on a CMP, right? When you order routine labs, do you get things like lactate or ketones or anything like that? No. You have to go looking for them as serum is concerned. So what's normally on a CMP? Those things that we are measuring. Chloride, bicarb, and sodium, right? And then sometimes potassium, which is also a measured count, but I'm not going to cloud the picture. All right? So if it's unmeasured, it's something else. If it increases that anion gap, that's this side. If it's measured, because it's chloride, it maintains the normal value, and so that we have a normal anion gap. All right? Yes?
So after this, we can just order, if something's off, I can just order ABG that shows the lactate and then say, okay, that's the other.
Exactly. Yes, exactly. That's exactly what I meant. When I said, I was kind of, tongue in cheek of like pH, bicarb, anion gap, it's increased, what's the problem? Then we order this stuff. Then let's get serum lactate, let's get ketones, and also again, remember this is an isolation without a patient in front of us, right? We have step 1 without any other information. And we have step 2, bicarb. Put those two things together, get the anion gap, now we figure out what the hell's going on. Do we order everything? No, right? We might have a patient in front of us. But yeah, is it lactate? Is it ketones? Did the patient overdose? Is it salicylate? Do we need to get that? Toxidrome? Something like that. Does that make sense, everybody? All right? So yeah, that is exactly right. When you find that gap, what's filling it? And that's clinically how we start to, and how do we do that? Solve the problem, right? Everything you learned about the diabetic ketoacidosis, right? Solving ketoacidosis, lactic acidosis, right? How do you treat that? You talk more about that in surgery and critical care, all right? Does that make sense? Yeah. Now we'll talk about normal anion gap, hyperchloremic metabolic acidosis, right? Okay. Literally, in this case, the easiest example is just physically washing out the bicarbonate-rich secretions in the colon. Diarrhea, all right? This right here, patient, what's missing in the middle? The bladder. This patient has had a cystectomy for bladder cancer most likely, or this represents a patient with a cystectomy. And what do they usually do to maintain urinary continence, at least some kind of urinary continence? They anastomose it to the sigmoid colon, all right? So what does that mean? That means the patient is essentially washing out a lot of colonic secretions with the urine that's still being produced by the kidneys, and so it's like having a diarrhea. Does that make sense? All right? You know the colloquialism peeing out of your butt, like everybody says that when they have diarrhea. This person literally does that, but it maintains a sort of continence for them so they don't have to have an ostomy bag, all right? And it's common, bladder cancer is unfortunately becoming a lot more common. But again, washing secretions out, physically losing bicarbonate, okay? So unless that patient has diarrhea or some kind of weird thing like this, which how would you know if this patient has had this? Past surgical and past medical history, right? There you go, the patient's in front of us, right? All right, does that make sense? And again, why is this a normal anion gap? Because we're losing bicarb, but what are we gaining? Gaining chloride, right? All right, now the weirdo kidney stuff, all right? If the patient has a normal anion gap metabolic acidosis, and we'll walk this dog, you have an ABG that tells you that you have an acidotic state. You have a bicarb that is also low, exactly, just like the pH. Now we have a metabolic acidosis. Next step is to calculate the anion gap, and we find that it is normal. The patient doesn't have diarrhea. They probably have a weird kidney problem, okay? And renal tubular acidosis. And again, not ironically named. It is a problem of a defect in the renal tubules, okay? So, little bit of brief, very brief, A and P, right? So here in the distal tubule, we are secreting, right? Putting acid into the tubule, so it will come out in your pee, right? Also in this distal tubule, we are reabsorbing or keeping bicarb, right? So two of the net same effect. We're excreting acid or reabsorbing bicarb, right? Essentially the same neutral, if you will, right? The proximal tubule here, we are also reabsorbing bicarb, okay? And we are excreting hydrogen. All right? Fair enough? That's all. A and P. You remember, Terry. So, type 1. Here's the trick about RTAs. Because they're great test questions, they're great pants questions. The easiest way to remember these is in a side-by-side chart that I have coming up. Because each one has a characteristic that makes it fairly unique. So I always tell students to study the differences because they all end up in a NAGMA, metabolic acidosis. They're all renal tubular problems. Boils down to where is the problem, what is the underlying problem, and what is the weirdo stuff that goes along with it. And that makes it go, let me just stick with me, okay? So in this case, what's in bold? It's a deficiency in hydrogen secretion, okay? So in the distal tubule, we are not getting rid of enough hydrogen, right? So what does that mean? It means we're holding on to it. It means net proton increase. It means now we are having an acidosis, okay? Same, just to compound the problem. It's not getting rid of ammonium either. So we're holding on to that excess. And so we have okay, when I say alkaline, everybody thinks it's greater than 745, right? Alkaline. But in this case, we're talking about your regular urinary pHs. The urinary pH will be on the high side. Okay, so not alkaline in the sense that it is literally on the pH scale alkaline, but alkaline in respect to, one, the clinical circumstance of this patient being acidotic. Because how should the urinary pH look if the patient's acidotic and the kidneys are working? It should be really low. We should be pissing out a ton of protons, right? But we're not, so we have a relative alkaline urine in the given clinical circumstance. Does that make sense? Okay, that's why I put that little asterisk next to alkaline, okay? Not that that becomes like a super high yield thing, like urinary pH, but again, this is one of the times where we might pay attention to it, okay? So, we have a deficiency in the distal tubule. We are holding on to too much protein, or proton, right, too much acid, all right? The other thing that makes this one unique is that chronic acidosis will predispose this patient to holding on to more calcium in the tubular filtrate, and that will predispose this patient to kidney stones. So what does that mean? It means RTA type 1 is a distal problem of hydrogen and it also has kidney stones. That's what I'm talking about when I say study the differences, right? Those three things, okay? Does that make sense? Kidney stones. Yes?
Sir, how do they have hypercalciuria if they are also holding on to calcium?
It decreased tubular calcium reabsorption. So decrease calcium in the tubular filtrate, in the tubules.
Oh, I see. Okay.
Right? Decreased calcium reabsorption, meaning more is staying in the urinary filtrate, meaning that's where it's forming the kidney stones. Yeah. Okay? Yes?
Is that calcium usually swapped with the proton, or is that just?
No, it's just because in the acidotic state, the tubules can't reabsorb calcium as effectively as they normally do. It's just, yeah, just a physiologic thing. So just put RTA type 1 with kidney stones. All right? Yes? I saw it. Yeah.
So the idea that like relative alkaline urine can point to this. So if you have someone who is acidotic, metabolic acidosis, and their urine pH is normal, would that be a flag for this? Because
It might be, because yeah, you would expect it to be low. Exactly, yeah. If it's not low, then that is weird. So exactly, you're right. You know what I'm saying? So if it's not if it's not low or the lower end of normal or way down, which is what you would expect. Because again, we're talking about the kidneys doing what they're supposed to be doing, that whole stupid thing I always say. And what if they're doing what they're supposed to be doing, we're washing out as much protein as we can so that we lower the overall pH. And if we're not doing that, it's going to point to a renal problem. So yes, all right? All right, so that's distal. Distal, hydrogen, calcium, stones, okay? And then highlights. Proximal, bicarb problem, right? So, last one, too much proton staying around. This one, too much bicarb being lost. Again, with the reabsorption. What does reabsorption mean? It means taking it out of the urinary filtrate and back into the system. So what does this mean? Literally, again, we're washing out our bicarb, only this time it's coming out in our urine. Does that make sense? Okay. So just quickly, this point is supposed to be clarification, but a lot of times students get stuck on it. Once the patient has lost sufficient bicarb, all right, the distal tubule can reabsorb the remainder, right? So the majority of bicarb is reabsorbed in the proximal tubule, the first part of the tubule. When this patient has gotten so low on their bicarb, then the DCT can actually pick up the slack and the patient will stabilize so they won't just continue to wash out all of their bicarb. All right? That's a very fine point, and if you don't want to remember it, you don't have to. Acetazolamide, you guys know what that is? Carbonic anhydrase inhibitor. It also can induce one. So if you give this to your patients, they can actually become acidotic. All right? Not always. Not always. Very rarely, as a matter of fact, but it's something you need to keep an eye on. All right? Is that patient hyperventilating because they're at altitude, or are they hyperventilating because they're acidotic? Or becoming acidotic? Yes?
So by default, this is not as severe as type 1.
No, neither one of these. So here's the overarching, high anion metabolic acidoses are usually life threats, right? Ketoacidosis, lactic acidosis, sepsis, those kind of things. Generally go with life threats. On this side, diarrhea is not going to kill you typically. This stuff, neither of these are like severe. Patients can usually walk around in this. So what you'll have is minor acidotic, unless they have really advanced kidney disease, and it's a whole different story. But so it's less severe and less likely to be less morbidity, mortality, I guess is what I'm looking for. Yeah. Okay.
Sir,
Yes.
will these patients also have a more alkaline urine since?
Yeah, they should.
Okay.
Yep. This one you might actually see in clinical practice. Those like RTAs, they're zebras. They're zebras, okay? But RTA, they're on the pants, so we got to know about them. Plus, this is kidney class. Type 4, it's usually something that you're going to see because of diabetes. All right? So, basically, the kidney has become, diabetes results in a nephrosclerosis, which we'll learn about soon. And so as that nephrosclerosis becomes more and more advanced, you lose functioning nephron mass. As you lose functioning nephron mass, you lose the ability to do the things that the kidney is regularly supposed to be able to do. So you get salt wasting, hyperkalemia, you get acidosis, and so that's something that you might see. So it's a cloudy clinical picture when the patient's kidneys really shut down and they're diabetic, because why are they acidotic now? But this one, type 4, is something you might actually see in clinical practice. It's associated with diabetes, all right? Like I said, this was not so zebratic. But what's going to give it away? A severe diabetic history, reduced GFR, increased BUN and creatinine, kidney failure, right? Okay. But then we'll be with your uremic next week. We're not going to go there. But here's the chart, all right? So just put them together, right? Side by side. One has kidney stones, one's a proximal problem, one's a distal problem, one is bicarb primarily, one is hydrogen primarily, other one is diabetes. All right, so if you set them side by side, just call out the highlights, and that's sufficient for renal tubular acidosis, all right? Clear? Make sense? All right. All right. Briefly, you guys don't have to worry about this. Fanconi syndrome, everything is wrong, right? The patient can't reabsorb. The kidneys are broken basically inherently. So the patient, they're losing all of their electrolytes, right? Don't worry about that slide. That's why I went past it, right? So eventually that means they die, right? So Fanconi syndrome, generalized tubular dysfunction. The reason why it's even on this is because one of the things that they do lose is the ability to excrete acid or retain bicarb, pardon me. So similar, but so those are the problems, right? If I have generalized treatment, we're really going to not touch treatment very much, and then we'll get into alkalosis. It'll be a little bit easier, I think. So, signs and symptoms of the underlying disorder. We've already talked about respiratory compensation. Why respiratory compensation? Try to blow out as much acid as we can to try to normalize, all right? And the laboratory findings, that is what we just did ad nauseum, okay? So, blood pH, serum bicarb, serum CO2 decreased, calculate the anion gap, so on and so forth. All right? This is literally what we've just been doing, is with the lab values, all of it, lab intense. Treat the underlying disorder, okay? So, again, we're focusing on the acid base itself here. Treat the underlying disorder, so we're not going to have a lot of treatment questions. Typically, do not give bicarb most of the time. Fluid resuscitation and treating the underlying disorder is sufficient. Talk to the, when you get to EMED, rarely give bicarb anymore. Sometimes it worsens the problem, all right? Treatment of RTA is nephrology. Yes, that's right. It is not a primary care problem at all. So if you find or discover what you consider to be a renal tubular acidosis, that becomes a nephrologist patient, all right? Any questions on metabolic acidosis? No? Okay. Now let's talk about metabolic alkalosis. A lot of times it's iatrogenic, all right? So now we were talking about diarrhea, we're washing out bicarb out the back. What if we are throwing up, we're having aggressive nasogastric suctioning? What is the stomach? It is a bag of acid, right? And if we get rid of it, we have a net negative, right? So we lose our acid, now we have an abundance of bicarb, so we have an alkalotic state, right? In alkalosis, our pH goes which direction? Up, right? Yeah. Okay. So you're going to see it called either chloride, or sometimes in the literature you'll see it called saline responsive. Sometimes this is just a contraction problem, literally like vomiting or overaggressive nasogastric suctioning. And so the answer becomes, we're giving them sodium chloride. Okay? Just giving them sodium chloride and it's responsive. And so chloride responsive goes with volume loss, right? So if we give them normal saline and they get better, then that's chloride responsive. If we give them normal saline and they don't get better, what do you think that means? It means a kidney problem often. It's a kidney problem, a generation problem. We're in kidney class, don't forget. If you say kidney, a lot of times we're like, yep, that's it, right? So chloride responsive is much more common because it's much more common cause is, if you will, all right? So again, hypotension orthostasis, what is that a sign of? It's a sign of hypovolemia. Right? Because again, we're pulling out volume, imagine this patient's throwing up. It's the easiest conceptual metabolic alkalosis patient to think of, all right? And again, if the patient's also hypokalemic, it's going to make the problem worse, right? And we're talking about critically ill patients, we're talking about somebody who's inpatient. If they're throwing up and they're also hypokalemic, then what are we doing? We're shifting potassium into the cell, right? Trying to shift hydrogen into the cell, to shift potassium out to resolve the hypokalemia. And so we're just driving the pH up because we're sending proton into the cell, all right? So nasogastric suctioning or vomiting, right? Let's just put either one, right? The same mechanism, where we're pulling acid out of the stomach, okay? That causes hypovolemia. In the kidneys, that causes increased reabsorption of bicarb. And so we have too much bicarb. But what does hypovolemia also do? What is the kidney's response to hypovolemia? The RAS, right? The renin-angiotensin-aldosterone system, right? And what does aldosterone do? Yeah, it keeps water and salt, and it also gets rid of potassium, right? So if we have a severely hypovolemic patient, now we're spilling excess potassium out, we become potentially hypokalemic. And now here's the cell. We're shifting potassium, I know you can't see that's a K, and we're shifting hydrogen in. So what happens as we shift more hydrogen into the cell? Our serum pH does what? Continues to go up, right? It becomes more alkalotic, right? Which means it leads to more of this, right? Does that make sense? This is just a diagram, right? And then again, the major problem is just this. We're losing the acid physically, throwing it, spewing it out, or sucking it out. Okay? Hyperaldosteronism, similar function. Right? Now these are chloride unresponsive, right? Because is a bag of normal saline going to cure somebody of their hyperaldosteronism? No, exactly. So it's not going to, it may temporize the problem, but the patient will right back to the state that they were in, all right? Same thing with decreased GFR, right? So if it's a kidney problem, it's not going to solve it. Again, it might temporarily improve it, but it's not going to make it go away, all right? And the aldosterone is that mechanism we literally just went through, right? So it's going to just drive this patient's pH up chronically, okay? And this is the point that I was talking about right here. Therapy with sodium chloride will temporize it, will make it better in the short term, and then it will just come right back. Chloride unresponsive. And conceptually, just think about it that basically. Will a bag of saline make this better or not? Right? Okay? And this is just the chart for you. You don't need to memorize, urine chloride values or anything like that. This, again, metabolic alkalosis is, I'd say, more nebulous generally, especially if the patient isn't vomiting. But all of these, nasogastric suctioning, vomiting, diuretics, right? Over administration of diuretics causes volume loss, right? So on and so forth, right? So it's a volume problem. So signs and symptoms wise, like it's not like this patient's going to slow their breathing down so much that they can accumulate acid. It might slow slightly, but bradyapnea is not going to be like tachypnea on the other side. So you don't really have any real classic signs and symptoms. But again, orthostatic hypertension, decreased skin turgor, signs of dry mucous membranes, signs of volume contraction. Okay. And then laboratory findings. Again, that's what we did at the beginning. We have an increased pH, we have an increased bicarb, an increased PCO2, so we have a metabolic alkalosis. And then we take it from there, right? Don't worry about it. Know that urine chloride is useful in this case, or sort of try to remember it slightly, but don't worry about the values or anything like that, all right? Really, with a metabolic alkalosis, again, the treatment is just administration of chloride or fixing the underlying renal disorder. Fixing the hyperaldosteronism, trying to regain as much usable kidney function as we can, or giving that patient renal replacement therapy, so on and so forth, all right? That's this slide, that's the bluff of this side. Treat the underlying disorder. If it's chloride responsive, re-expand their volume and they'll be fine. If it's not, fix the underlying disorder. Okay. Questions? Yeah, metabolic alkalosis went a lot faster. Respiratory, we're going to go even faster because we're not in pulmonology. You can get Crazy Susan in here, she can do it for you. All right, so hypoventilation, respiratory acidosis. Your respiratory acidosis, what are you doing? You're going to start Who's our typical pulmonary patient that has respiratory acidosis?
Old smoker?
Yep, COPDer, exactly. COPDer, for whatever reason, old smoker is a great one. Okay? Usually COPD because they're not oxygenating enough, they're not breathing enough. Okay? And so signs and symptoms are hypercapnia, somnolence, confusion. Arterial pH is low, PCO2 is high, bicarb is high too. Right now, we're in respiratory opposite, right? Make sense? And, give them oxygen, do whatever you gotta do. Respiratory alkalosis, same thing, hyperinhalation, everybody, first day, freshman year, test time, right? Everybody passes out. Lips get tingly, hands do this, right? You ever see that? People think they're having a stroke because they start hyperventilating, their lips get tingly and they have a carpopedal spasm. And like, oh my God, what do I do? And like, settle down. That's what you do. So. And then treatment of the underlying disorder, right? Don't have them breathe into a paper bag. You can, it's funny, but. I know we went fast, I know, because I know we went fast on respiratory stuff, you know why? Because I don't care, because it's not pulmonology. If you can, what do you need to identify a respiratory disorder if I give you ABGs? The pH, the bicarb, and the CO2, right? Are we on the same page? You picking up what I'm putting down? All right, good. All right. Chart. Second chart. Third chart. Okay. Questions? Don't start packing up yet. We got to make some use of our time today. Okay, any questions? We have a little bit more time that we're going to utilize. That way you guys can push EMED up as far as you can. I am going to use the second block, but probably not all of it. But I want to get that. The next stuff is so much easier, you guys. It's going to be like a breath of fresh air. A breath of fresh air. Okay? Does anybody have any questions about the stuff now? Again, acid-based stuff, it's intimidating when we talk about all of the middle portions of what's going on. If you can just analyze an ABG, that is good enough for not just this class, but phase 2, all right? If you can just understand the generic mud piles or gold mark, and if you get a clinical scenario and it says what would be expected in this patient, that's good enough, all right? And what would be expected in this patient for either mud piles or gold mark? High NIN gap metabolic acidosis. That's really it. And be able to calculate an NIN gap, okay? Don't forget that part. Now I know, again, when you put this back to back with the fluids and electrolytes, you're like, this class sucks, I hate everything about it. It's gonna get easier, all right? It's gonna get easier, all right? Like I said, everybody from the last class graduated, they weren't that bright. So they're gone. So, all right? So just stick with me, all right? No, I love the last class. All right. I like you guys too, though. Extracting some personality, the personality extractor. I feel like finally we're getting to know each other. All right, let's do some review. No, I'm not gonna do it now. Any questions? Anything? You're gonna be surprised how easy this next one is. That's why we're gonna do it, because it's fast. And then you guys can go and take a lap or whatever you gotta do. What did I say about hematuria and protein? What did I say about blood or protein in your urine? Never let it go unexplained. Never let it go. Whatever you guys just said, yes, probably I said that too. But never let it go unexplained, all right? It's seemingly innocuous, very seemingly innocuous, especially if it's microscopic, or if you have potentially even a source to explain it, right? If you have somebody who's doing an intense workout and they come in after PT and you get labs, they're gonna have some protein in their urine, maybe even a little blood. Don't let that go, okay? Because that might be your first window into an opportunity to treat what might be the onset of chronic kidney disease, all right? Dollar for dollar, side by side, and we're going to talk about this over and over again. Proteinuria portends a worse diagnostic outcome or worse prognosis than somebody without proteinuria. So proteinuria is one of the key clinical indicators that predicts that this patient is going to have a poor renal outcome over the long term. all right? It's one of the most important things you can stop if the patient is proteinuria. So that's why I said never let it go. You got to understand, is the hematuria, is the proteinuria transient? Was it just something that just happened? Or is it persistent? And if it is persistent, you have to figure out why, and you have to make either appropriate referrals or appropriate treatment decisions, okay? So that's the preface of this. It is easy, okay? Because you don't have to memorize normal values, I'll give them to you, all right? But you have to understand that these are important, and they can really, yeah, I've been there, and you're gonna be there too. You're gonna be on your, 30-second patient of the day, you're gonna be looking at labs, you're gonna see a bunch of H's, you don't have time for this shit, the guy looks normal, he's fine, what do you need, what do I have to give you to get out of my office right now, right? Don't, just pay attention, follow up those labs, take a breath, do whatever you gotta do, have a beer, and then treat the patient's proteinuria, all right? So, we have protein in the urine. And what am I really talking about? When I say proteinuria, what am I really meaning? What protein? Albumin. I'm really talking about albumin urine, okay? And so we got to quantify how much, try to figure out how long it's been going on for, all right? Oftentimes it does indicate kidney damage. In most cases, if the albumin is spilling, it's because of an abnormal glomerular permeability or glomerular hypertension, something along those lines, right? Something is wrong. And you think about it, you guys remember the Play-Doh thing where you put the Play-Doh in and you squeeze it, and spaghetti shoots out? All right? All right. So, think of the thing where you put the Play-Doh in as the glomerulus, right? If you put too much pressure on it, what's going to happen? Albumin is going to shoot out into the tubular filtrate and you're going to have proteinuria, all right? So what do we got to have to try to do? Reduce the amount of pressure in there, possibly. How do we do that generally? What's the one word? What's the two medicines? ACE or NARB. I told you, subscapularis is the answer in ortho. In nephrology, ACE or NARB is the answer. Just go for it if you don't have any other, if you don't know what else it is, all right? So, again, don't have to know this, but we do have to know that there are thresholds and there are boundaries. What constitutes normal? There is normally protein in your urine. Even a tiny, tiny little bit of albumin. But what there is mostly is a uromodulin, that TAM horsefault protein. I feel you. I got it. I'm just messing with you. God. I even do this sometimes. I don't know if you're like, I can't even take it anymore. But mostly uromodulin. That's a TAM horsefault. Anybody remember what that TAM horsefault mucoprotein, what does it do? Cas. Yeah, Cas. It becomes a little skeleton matrix that stuff gets caught in and it comes out in the Cas. But it's normally there in some quantity anyway. So if you do a total 24-hour proteinuria, it will tell you how much of that is in there as well. What we're really concerned about mostly is the albumin, all right? 30 milligrams a day, all right, is normal albumin excretion over the entire period of the day, right? Now, this is where this comes into play, why this is such an important test and why it's so critical that you don't miss it or fail to do it when you're following your diabetics. All right? Diabetic nephropathy is going to happen to your patients who have diabetes. Their kidneys are going to fail. All right? What is our job is to prevent that failure for as long as possible. And what do? We keep an eye on their kidney function, and one of the things we specifically go after is microalbuminuria. You remember me telling you that we don't preemptively screen for renal disorders in an otherwise healthy population, right? We're not talking about an otherwise healthy population. We're talking about patients with diabetes now. We're looking advanced. We're going after their renal disease. So we're watching their BUN creatinine and their EGFR, and we're looking specifically at if they start spilling protein. And if they start spilling protein, what should every diabetic be on? An ACE or an ARB, in addition to their glycemic control medications. Yeah. All right. And then 3.5 grams a day when we really get into nephrotic range protein. We're going to talk about nephrosis in the next coming, I think, Monday or something like that. But look how much, if you're waiting for the dipstick to be positive, right? They're already in fairly advanced renal disease. Because when we talk about chronic kidney disease, it's measured on two different axes. One is the amount of albuminuria, two is the reduction of GFR. So albuminuria is a very important parameter in established renal disease. So if we're waiting for them to be spilling 300 milligrams a day to become dipstick positive, we've waited too long. This patient already has renal disease, all right? All right, so remember me saying that in a race to death, the kidneys usually win? Microalbuminuria is one of those things that's going to help tell us how the kidneys are doing in that race, right? We develop renal disease, they're going to develop heart disease, and once they develop heart disease, then it's going to take the liver with them, and they're going to spin down. You know what I mean? So the presence of albuminuria increased all-cause mortality and increased things that will kill them and create that cardiorenal syndrome. All right. And again, even independent of the underlying disease process or level of kidney function. So like I said, two different axes. eGFR is one way to measure it, but proteinuria is an entirely separate axis. We'll measure proteinuria. A person with two people side by side with the same reduction in eGFR, right? Let's say they're both in the 80s, which is below normal, right? But one has proteinuria and one does not. The one with proteinuria is worse off. It's going to have a worse renal and cardiac outcome. Hopefully it should make sense that if they have two different symptoms, it's going to be worse, but let's understand how important that proteinuria is. All right? And this is just a visual representation, right? The people with the red bar have the largest amount of protein that is being spilled, so all-cause mortality, cardiovascular, making their kidneys worse, acute kidney injury, so everybody know what a de novo injury is? So the de novo injury is a new injury, so they have new acute kidney disease for some reason. And has anybody heard the term acute on chronic? So you have chronic kidney disease that predisposes that patient for an acute disease on top of that, because their kidneys are malfunctioning as it is. So even that even not only just getting their kidneys worse in general, but worse establishment of acute kidney disease. So this up and down cycle of this patient's kidneys going bad. What do you think that does in the long term? Eventually just finishes them off, okay? Different types of proteinuria. This is the one that generally, I said, people tend to write off because there's an obvious reason for it. Like if you have somebody who's coming after a marathon or a CrossFit workout or whatever strenuous physical activity, you expect a little protein in their urine. So I just caution you not to write it off, right? In most cases, probably 99% of your patient panel, it's going to be transient proteinuria that goes away. But there's always that 1%. And that 1% is what you want to catch, all right? Then we have glomerular, which is what I was talking about with that squeeze, right? The whole Play-Doh thing. That's what we're going to talk about in the next coming lectures. That means basically the glomerular filtration rate has been adjusted and the glomerular permeability is off. So basically this huge, large molecule that's supposed to have multiple layers of filtration to keep it in is escaping out. And that's what causes the proteinuria. Tubular proteinuria, again, we'll talk more about that when we talk about established renal disease, right? And then orthostatic, you want to talk about in peds. It's really more of a pediatric problem, but you get two samples. You get a 24-hour urinalysis, but you get an upright sample and you get a supine sample, right? So in the upright sample, the patient has orthostatic proteinuria. Imagine literally the protein squeezing out into the urine, right? But then when they lay down and they're supine overnight, the overnight sample has a resolution of the proteinuria. That's how you diagnose orthostatic proteinuria. And again, a lot of times it's in kids, and it resolves. And then overload, you guys will talk about that a lot when you get to the onc section, plasma cell myeloma. That's typically what that is. You guys remember urinary protein electrophoresis, serum protein electrophoresis, those terms, right? So you have an overwhelming abundance of a production of an abnormal protein, an IG of some type, right? So when you get a monoclonal spike, you guys remember those terms hopefully. But anyway, we're not going to talk about overload proteinuria anyway. Evaluation of proteinuria, this is the easy part. Usually we find most renal disease incidentally. Like we don't often go looking for renal disease other than diabetics, right? Diabetics, hypertensives, okay. But in most time, renal disease is fairly silent, especially at the early stages, even into the late stages. You have to be really sick to have a lot of these uremic constitutional overt symptoms. A lot of times there's not much of anything, which is why a little bit of protein or blood spillage in the urine early on is so important to catch, because then you might be able to save this patient's renal function or preserve it for as long as possible. Anyway, what do we want to get? We're going to start with a dipstick. That's usually how we find it. We just stumble onto it, right? I said incidentally sounds better than accidentally, or sounds more intelligent anyway. So we get an incidental finding of a proteinuria on the dipstick, right? Measured from 1+ to 4+, right? Anything above 0 is, protein should be negative. So if you get a 1+, because that's really detecting albumin, that means it's off. And then what do? Get another one. Right? You guys anybody boxing, UFC fan, anybody, wrestling fan, know what a rubber match is? No? So two fighters fight, one wins, they fight again, the other one wins. So they fight a third time, that's the rubber match to see who the winner is. That's what we have to go with when we're talking about protein or blood, right? We get one, it's positive. If we get a second one and it's positive, well, we're good. But if we get a second one and it's negative, now which one is right? And we get a third one. Does that make sense? Okay. And then again, what we're looking for is anything other than neg is abnormal, right? And again, I'll give you these values, but just if you see protein in the urine, it's not supposed to be there. Because again, what is that dipstick testing for? Albumin, right? Dipstick proteinuria is not going to give you Vince Jones or uromodulin. It's going to say negative because it's really testing for albumin, sensitive for albumin. What's the problem with the 24-hour urinalysis? Patient compliance. Yeah. Patients don't like to pee in a bucket for 24 hours. They'll forget. They'll get up in the middle of the night. They'll piss in the bowl. Oh, well, now that's wrong, right? So it's notoriously difficult. Easier if the patient's inpatient and they have a Foley and you can do it for them. Harder if they're not. You have to get it sometimes. You really, truly need to quantify urinary excretion of a substance because everything else is an estimation, all right? But we have good estimates now that are more useful and significantly more practical than this, all right, than carrying around your pee for 24 hours, all right? Because honestly, even if a patient the patient has to go to work or school, they don't have to go run to the bathroom with their pee bucket every time they go to the bathroom, So then they'll alter what they do, so you won't even get a true reflection of their normal daily ins and outs. So it's just, if you have to do it, you have to do it. But if you can avoid it, you can do these spot samples, okay? So UACR, urinary albumin to creatinine ratio, that's our common one to evaluate for proteinuria. So something you would order. That's your microalbuminuria test. Right? That's what microalbuminuria test is, urinary albumin to creatinine ratio. Okay? There's another one called UPCR, protein to creatinine ratio. So that's somebody we're following for established proteinuria, potentially of another cause. All right? So just UACR is going to be your more common one that you order. And how do you order it in Genesis? Typically, you just put microalbuminuria. Right? When you want that, because that's really what you're looking for. In that patient, that's a spot sample, so you don't have to have this patient pee in the bucket for 24 hours. You don't have to have them fast. You don't have to do anything. You just get it. Okay. And then just step by step, quantify proteinuria through either the spot sample, right? You catch proteinuria. What do? Confirm it, quantify it, right? Let's see, now why will we need a CMP or a BMP? CMP is really what we need because what's missing off of BMP that we would have on a CMP? A lot of things, but what have we been talking about? Albumin. Albumin, right? Total protein is going to go on there, albumin, right? So if you're hypoalbuminemic, that's really important. Also, it's going to have everything else you guys just said, BUN, creatinine, EGFR, right? Those will be on your BMP, but we also need to look at our albumin. See if they're spilling sufficient to become hypoalbuminemic, then we have a whole different set of problems on our hands, right? hyperviscosity, hemoconcentration, thrombosis, so on and so forth, right? Lipid panel, that might not make inherent sense to you right now, but it will when we talk about the nephrotic syndrome. Remember me saying that fat and protein go with the nephrotic syndrome? One of our primary renal disorders that causes protein spillage is nephrotic syndrome, and so we would find hypertriglyceridemia, potentially even lipiduria. You guys remember lipid cast, oval fat bodies? Okay, things we've talked about already. And then, just to make sure for in the complete evaluation of proteinuria, those electrophoresis. You guys remember what electrophoresis is? Huh? Theoretically, you use electrophoresis for DNA. In this case, basically you put, some of the patient's urine or some of the patient's blood into like an agar sort of medium. You shoot an electricity into it, and it things travel in an expected pattern, right? So they travel an expected distance over a certain expected time. And so the little graph thing should look a certain way, right? When you have one that has like a monoclonal gammopathy, which is what plasma cell myeloma is, you have this weird spike at the end. Right? So it's just a lab test, but that's what electrophoresis is. And yeah, you can use it with DNA as well. So again, but then that's testing for other kinds of proteins. And then renal ultrasound, like I said, any kind of time we're establishing chronic kidney disease or looking for it, get a renal ultrasound to see if they're asymmetrical or if they're bilaterally shrunken, okay? And then, once we get to that point, this dotted line really represents the end of primary care, because we're really not, send them on to nephrology or urology for the biopsy, okay? And then, again, why is it important? Why do we get generalized edema from hypoalbuminemia? Oncotic pressure, loss of oncotic pressure, third spacing, that is right. Okay, pulmonary edema, same reason. An increase, you guys remember talking about cirrhosis, and then ascites, and then what happens, I don't know if they do it, but I always talk, static fluid anywhere in the body is bad, right? What does static fluid become? A swamp, a place, an agar plate, somewhere for shit to grow. So static fluid anywhere is a bad thing, okay? Proteinuria treatment in general, very general. We're going to talk about treatments much more when we get into the individual pathologies, but what did I say? ACE or an ARB. And why? Because it reduces the squeeze on the Play-Doh. Okay? It keeps the Play-Doh in the blood where it belongs and out of the urine. Alright? And then, oftentimes if we, before, I said renal biopsy is possible in the treatment, but we're really, this is a kidney doctor problem in general. So we send them to the kidney doctors to figure out what exactly is going on. Alright? Okay. These guys, SGLT2Is, I'm sure you talked about them quite a bit, right? They do everything now. Them and GLP-1s, they do everything, right? So, SGLT2Is actually have been FDA approved to treat chronic kidney disease. And so if you have an established proteinuria patient with chronic kidney disease, they should be on one of these flozins, all right? They really do a lot to preserve renal function, and not just in your diabetic populations, okay? But they really do also help with established proteinuria. So there's just a little picture of what SGLT2Is do. I'm not going to go over that because, again, this isn't farm class. Just know that you need, if you have an established CKD patient, they should be on an SGLT2I or a GLP-1, okay? So you can see how recent this is, right? So I mean, we're just starting to scratch the surface of everything these medications can do. GLP-1s haven't been specifically FDA approved for chronic kidney disease yet, but again, give consideration because they can preserve renal function and delay adverse renal outcomes, which again, when we have a chronic kidney disease patient, that's what we're trying to do. We can't regenerate we can only lengthen the usability, all right? All right. What do we got? 8 minutes? All right. You guys want to go? All right, go. Get out, go, do something. See, what do we say, we're gonna take a half an hour? I'm not talking for 4 hours straight, you guys. So, we're gonna take a half an hour or something, do that, take a lap, and I'll be back in, let's say, we'll call it, what do you say, 12:15? 12:10? 12:09? 12:08? All right. No, I'll give you the value. I'm giving you this because you can get 1 + 2 + 3 + 4 +. See, that's what these values mean. You don't have to memorize it. I mean, honestly, really trying to keep my know. 0 is good, 4 is bad, right? The higher the number, the more good. So you don't have to memorize the equations. I just had a question that has those numbers represented. When you get all proteins.
Yeah.
What's part of it? So if you get a 24-hour urine out, yes, you'll get a total protein.
It's literally very big. Yeah, I'm not trying to grow. Yeah, the adults switched down to right now.
Yeah, alkalizes urine to a certain extent.
Yeah.
Oh,
These
yeah.
ones I don't actually have to sink
It's a really important
I just don't like the. I mean, I like the sooner on. I don't want to take it one, but it's a little baggy right now.
reabsorption.
You want to go? Ride the car and talk.
Where we going?
I'm gonna run out.
The
Units.
Let me go check in my
You don't want to look it up?